Thank you very much, the three outstanding speakers. We have time for questions. Please come to the microphone so everybody can hear your question.
Hi, I'm Paul Mick. I'm a neurotologist and public health researcher from the University of British Columbia. Just to everybody, it seems clear that there's association between hearing loss and physical, psychosocial, and functional outcomes. But can we predict the people who are going to be most at risk for these negative outcomes beyond sort of the severity of their hearing loss? Which factors predict good outcomes and which factors predict bad outcomes?
In the literature that I reviewed, my answer would be the research is not sufficiently mature to answer those questions as yet.
I'm Donna Sorkin. I'm the director of the American Cochlear Implant Alliance. I think what I heard all of you say is the little bit of work that we've done on the effect of hearing aid use typically did not get at a fine-grained look at how well people were fit, whether they had received rehabilitation, et cetera. And I'd like to make a pitch for ensuring that when we're looking at hearing aid usage, particularly in the severe to profound range, and we know from the data that most people who use hearing aids have a severe to profound loss. And many of them actually should be using cochlear implants because they're not getting sufficient benefit from amplification. So we really need to distinguish between those people who are fit appropriately and are getting appropriate benefit from them. My 89-year-old mom has a moderate loss, does dramatically better with her hearing aids on. It is astounding how much better she does. Clearly, if she were in the severe to profound range, maybe not that same kind of benefit. So when we design those studies, we really have to make sure that we're looking at how well people are doing with their amplification, and also take a look at those elderly cochlear implant users who have had moved up to that level, and how that's affecting both the dementia scores and the functional physical scores as well.
I would put in a plug there. We know that cochlear implants are effective in improving quality of life in elderly individuals. So that's definitely true. And yes, there is a huge need for randomized controlled trials on the efficacy of hearing aids in terms of the outcomes that are important in terms of public health outcomes. And we have to, of course, have good measures of the hearing aids. We have to make sure they're fit correctly. There's a lot of variables, but I think the studies that, and also most of these studies that looking at the psychosocial consequence of hearing loss and include large groups of hearing aid users, the hearing aid use is an after question. But I think the issue is that the people with hearing aids are doing better than the people without hearing aids, but they still have significant problems because they have other issues as well. So it's a very packed question. Thank you.
And I would just add, obviously, Alan and I were debating slightly whether or not a randomized controlled trial is what's needed next. And I would argue that it is, and that part of the thing you would want to do is to see how well hearing is improved by people wearing hearing aids. So an observational study saying you're using one or not wouldn't address the question that you raised.
Two comments, one complimentary, one perhaps provocative. I do think that intervention studies with the proper intervention are essential. But I would also caution it's not just hearing aid. It is all rehabilitation and it's speech reading. Otherwise, we're not really looking at what's possible to do. But I think that's true across all three domains that you guys discussed. More and I blame myself for this as well. I'm struck by how ageist all of this research is. It all starts almost with I'm stating this a little strongly, but it starts with an assumption that old people, the real issue about old people are keeping them, avoiding morbidity or like dementia, keeping them functioning or improving their psychosocial function. The real question we're not asking is their ability to work. What do they retire earlier? Are they continuing to work? We know, in fact, that 1/3 of older people have to work. They don't have financial resources to do otherwise. What's their ability to contribute through work? How much do they volunteer? And to what extent do they participate in informal helping in the family, taking care of grandchildren and other people? If we start with the view that this is just about non-functioning people who aren't expected to contribute to society, that is an ageist point of view. We have to turn this around and say we have this tremendous resource of 78 million people, baby boomers, growing older, and the most important imperative is to keep them working and contributing, and what's the effect of hearing loss, untreated and treated on those outcomes.
Well, my questions have actually just been preempted by the previous two speakers, but I do think that the end point of this is that, assuming you're going to be testing now how well hearing aids work in the individuals who you're looking at for cognitive decline, and I'm assuming probably that you're going to find out that good hearing aids and good hearing correction probably do reduce the amount of dementia. But that leaves all of the people who are wearing hearing aids that don't work very well for them. And part of it has to do with, as you say, rehabilitation and other kinds of just learning, to wear your hearing aids all the time, and even if they're properly fitted. But the end point is that we need better hearing aids. And so, I'm not really sure who's in this audience, but the hearing aids are not very effective for many, many, many people, including many, many young people in the workplace. And so the fear of dementia is, it's terrifying. But also, if we're going to be measuring hearing aids, we have to measure how well hearing aids work. And then we have to put a lot of pressure on to make those hearing aids work for everybody. So.
Good morning. I'm Sergio Guerrero, and thank you very much, Barbara, for your HHIE, because that made my thesis, and Terry, thanks. And hearing aids do work, and as we proved it along with oral rehabilitation. So one comment and then one question. And I think that, we always look at this data that is sometimes can get old on the issues of hearing aids. But, I think we talk about, is hearing loss a medical crisis as we develop? And I think it is. But yet we don't treat it that way. You're sick, you get an MRI, you're this, you break, you're this. But I think that I love the idea of why the medical model doesn't fall onto hearing loss as it does for cancer or anything else. Why aren't we doing MRIs and doing functional MRIs to look at how a patient's responding, and then after treatment, do we see plasticity improve? Are we looking at, is our outcomes with treatment better? I mean, we're all heading this direction to where pretty soon we're going to be paid based on outcomes and best practices and how well your clinic is doing. So that's sort of one question about looking at post-treatment, do we see patients getting better? Regarding the hearing aids, as an audiologist, that's what I do, is I try to help patients. But I think that the industry has faulted and created more of the mess that we're into. I just Googled living well with, and I can tell you that hearing loss never comes up. Is living well with arthritis, diabetes, alcoholism. This is stuff that we put on ourselves, right? Alcohol, drugs, we do this. This is part of life. So living well with everything. But what I hear is that hearing loss affects us in so many ways, and it's disconcerting that the industry is pushing out all these hearing aids at 142 decibel output to do what? To loosen your molars? I think there comes to the point, hearing aids work, but you have to have outer hair cells. You have to have a mechanism, because this is an external device. What happened to the implant that basically then goes back and sends the nerve that stimulates the dendrites on the nervous system for you to hear again. I have patients with implants that I don't know, that they don't hear. So this is an industry issue, and I wish that this council would be more proactive with the hearing industry to get them to really fine-tune what their missions are and make dispensing and the rehabilitation more directed at patient outcomes to prove that what we do does the right thing for them to stay active. It's just a comment, but thanks.
And also add, as long as I am up here, and you can't throw anything at me, hearing aid people, manufacturers here, why is when you get a hearing aid, many people, the biggest problem people have when they're using hearing aids is, or they come in for hearing aids, difficulty understanding speech and noise. We understand that the way in which you can overcome that problem is ensuring that the speech is, one of the ways, the speech must be louder than the noise, so you got to get that microphone close to the speaker. So why is it that now people have to pay an extra $500 for a remote microphone and then an extra $500 for the streaming to enable you to use the remote microphone, when in fact the whole reason why they're coming to you is for that device that's going to help you understand better noise. So I think it's really, really important that we don't keep adding on to the cost of a product that is so expensive. And with those products, of course, there's problems in terms of figuring out how to use them. So I will underscore what you suggested, and I'm sure that we have an audience with an open mind here, and hopefully we'll take it back with them.
Okay, I have been fascinated by this for a long time, and I was sitting listening to you, and I thought, if I were a clinician, I would be really confused right now. And I think I think we need a few more dimensions to our thinking. So we are talking at one extreme about the kind of people I saw in the clinic that made me want to go and do a PhD in cognitive psychology, and these were the 40, 50-year-olds, pre-retirement adults, who had problems, but they did not yet have enough hearing loss that they were really obvious candidates for a hearing aid. And then on the other extreme, we have, people that are wearing cochlear implants. So we have an enormous range of hearing problems. And then we also have an enormous range going from the 40-year-olds to the centenarians. And I think, we are never going to have a one-size-fits-all. And kind of wrapped in that huge space of age and hearing loss are the questions, how early is early enough to do something? And we think we should start earlier, but how early is early enough? And then the other question is, and when is it too late? So I think maybe those are ways of pegging this enormous territory that would help the clinician to figure out, when should I do something and when should I stop doing something? And then the other thing that runs through my mind is, well, we've got this small percentage of people using hearing aids, and we wring our hands about that. But maybe it's because the rest of the people with hearing problems need other solutions. And one of the pieces of advice that I was given when I was interested in developing the concept of hearing accessibility was given to me by a person who was in a wheelchair, and he had been a leader in the anti-landmines movement. And his advice was that we were never going to get anywhere as hearing professionals if we continued to talk about hearing loss, because it was a minority issue. But if we talked about hearing accessibility and communication accessibility in the spirit of universal design, and that everybody should have a conducive environment for communicating, then we can actually go to the population level and we can actually make a difference. So just some ideas about, the new territory that we're trying to understand.
So Kathy, can I just quote one of your colleagues from one of the early studies that came out of your facility on hearing loss and when to intervene? And the quote is that we must intervene before hearing loss becomes an intolerable burden. And that's, that's early, but we can't, but the Mercedes $6,000 hearing aid is not it's too, we need to intervene early with the targeted interventions, selective.
Maybe Frank, at some point will get us to an analogy, to another chronic health issue like diabetes. You don't wait for somebody, or hypertension. You don't wait for somebody to be having a heart attack or collapsing before you start giving them education about lifestyle, before you, have these softer interventions that predispose people for readiness, for self-management, and those are just not things we do, and why not?
So I would just make the comment that in this room, we have people who are concerned about hypertension. We have people who are concerned about treating dementia. And the way that we learn about when to treat people and how ill they need to be before we treat them is by starting to treat them, by having randomized trials and looking at the outcome. That's how we learn the answer.
I think the speaker on there was.
Dr. Furch, you going to say something?
Oh, please.
Thank you. My name is Valerie Fletcher. I run the Institute for Human-Centered Design, international nonprofit dealing with the role of design in minimizing limitation. My question is actually about the characteristics of all of these study samples. I've heard only gender and age noted, and we've talked a lot this morning about the cost of hearing aids and cochlear implants and the lack of coverage for that. I'm really curious about the demographics of culture as it relates to hearing loss and economic status. Because with our nation moving in the direction it is inexorably moving, we better be thinking about those things too. Thank you.
I think you make a really good point. A lot of the literature did not dig deeply into some of those other demographic factors. So it's a really good point. I think the literature has really scratched the surface in terms of really understanding the potential modifying effect of various types of hearing assistive devices.
It's Chris Roberts, Cochlear. I really enjoyed the review of the literature. You'd clearly read a lot and prepared a lot. But overwhelmingly, it was about correlation and association, but the thing that matters is causation, and this area won't move forward without causation or without better causation data. And my interest in listening to your reviews was to try to tease out from what you were saying which bits did relate to causation, because there were elements of it in what you said. And I just wondered if the speakers could go through their respective areas and make some comments on what they thought the literature said in their areas relating to causation.
Who has the courage to address that question?
Very little. I mean, I tried to focus on longitudinal studies primarily so that we could have a clear time order. So I focused on mostly cohort studies. I did not focus on a lot of experimental studies. The closest would be the driving work that I reviewed, so I would say that comes closest.
And I would say the same. The reason that I emphasize longitudinal studies is that seemed to get closer to a real relation, a causative relationship, but it's still at the correlational level. We have a lot more to learn.
In terms of the cause and effect, I guess there were a couple more slides that I wanted to show in terms of hearing aid interventions and the effect on caregiver burden and the effect on depression and effect on quality of life. And I guess but those are not very strong studies, small studies, but the earliest studies, Cynthia Mulrow and her group of physicians in Texas in the 80s, they did their study and they looked at they gave individuals hearing aids, they measured over time quality of life, non-hearing aid users, hearing aid users, and they did find, for example, that people who used hearing aids over time, there was a reduction in depression. Whether or not there's a causality thing, but they did suggest that. So perhaps if we, that's why we have to do these studies, because there are no good randomized controlled trials on the the outcomes with hearing aids that would even get us even closer to the causality issue. But at least these correlational studies, these longitudinal studies, these cross-sectional studies give us a feel for what we now have to go after.
Thank you. Just a very quick follow-up comment, which is perhaps a rhetorical question, but are we at risk of overblowing the public health problem without causative data if we only rely on associative or correlative data?
From a public health perspective, the U.S. Preventive Services Task Force did not endorse screening for hearing loss, nor did they endorse screening for cognitive decline, but they didn't endorse screening for hearing loss because we do not have the outcome studies that show that if we do intervene, our interventions are going to have that beneficial effect.
Okay. Yeah, I just wanted to bring up a comment, and it was something that struck me at the end of the last session as well, where somebody said, how can we make hearing loss more visible? And likewise, in this session, when we talk about treating hearing loss, it strikes me that what the problem is nobody thinks about hearing loss until people are reaching middle age, and then it's all of a sudden hearing loss is important. But we don't, with very few exceptions, people are not talking about hearing loss to younger generations. I mean, okay, we talk about prevention of hearing loss and not going to lousy, noisy discos or whatever they're called these days. But I think the point is that the awareness that we need to hear, we need to communicate throughout life, I think is something we need to sort of start getting to the younger generation, just as a way of thinking. And then people, as they get older, will be aware that their hearing may deteriorate, and they do need to keep putting the emphasis on being able to hear and communicate.
Oh, hi, I'm Meg Wolhagen. I just want to I want to echo that. I think we need to look at really design of public health issues, especially when arenas try to compete with each other in terms of being the loudest. But I wanted to also raise the issue around doing studies, because being engaged in a lot of studies related to older adults, I get concerned sometimes about maybe coming up with some very creative designs. I worry about the ethics of randomized controlled trials in certain situations where not providing someone with an intervention raises multiple kinds of issues. We know that, at least if you look at the smoking literature, and of course that was a very strong relationship, that's mainly observational, but it was over time, and they were so strong that they found, they were able to finally say, this is really negative. So I think it's not that we don't need the causative information, and randomization is usually the gold standard, but I do think we need to think of maybe other creative research designs to look at some of these issues so that we don't run into the ethical issues of treating versus not treating people who we really feel probably need the treatment.
Hi, I'm Becky Broad. I'm a geriatrician from Pittsburgh, and I was just wondering, in the aging field, we tend to have a lot of difficulty getting the primary care physicians and just the general medical community to accept some of the outcomes that we're talking about, like cognition, functional decline, and I'm wondering if maybe we should be targeting some other outcomes that are already focused on in kind of the primary care arena. Outcomes with disease specific for diabetes or hospitalizations, reimbursement, other topics that are kind of hot topics when in kind of the general medical field as well, and seeing if we can impact outcomes in that area.
We have time for at least another. I have a question. You mind? I mean, this has been a really, really interesting morning, and the number of questions that are forming in my mind. One of them is, what is the state of the research or risk factor that predict who is going to do well or is not going to do well with a hearing aid? I think that's a critical question, and because it's really decoding. There are probably cognitive components that may predict who is going to do well or who is not. And I also have a second question, which is related to the previous question. If we really think that the load is important, the brain does a lot of things. And among those things also regulate metabolism. And have somebody looked at whether hearing loss is associated with the chronic disease? I mean, diabetes. She was talking about diabetes prospectively, not the cross-sectional association. This doesn't count here, but maybe there will be a vehicle by which we can talk to the primary care physician and say, it's not just communication. This is going to have an effect on something that you know very well and you recognize very well and you are already trying to prevent. It may be a back door to make people do that.
Well, obviously, there are lots of large longitudinal studies that could be analyzed to address some of the questions that you raised. For sure, diabetes as a risk factor for hearing loss. I was telling Frank the other day, I personally know of somebody who had a very dramatic loss of hearing, partly because of underlying diabetes. So I agree that would be a very good avenue to pursue.
I would also add, I thought Jim Furman made a really very convincing argument that we need to go in both directions. I mean, he's arguing that we really need to look at community levels of participation, work, driving, independence, engagement as a parent, as a grandparent, as a caregiver. These are important social roles that could be severely compromised by hearing loss. They've not been well studied. There's some work, but it's not. I mean, so I think both directions. I think those are profoundly important societal roles that deserve investigation, as well as the more medically oriented issues as well.
I love that you mentioned volunteerism.
Yeah.
Well, I would say that I had a patient who, the reason why he was able to increase his volunteerism is because he got a hearing aid. He got hearing aids and that helped him. But who will do well and who needs hearing aids, that's a packed question, because how do you define who will do well? But in terms of fulfilling societal roles is obviously very important.
Well, if there are no other questions, thank you very much. We reconvene this meeting in an hour at 1:15.